good high efficiency, availability, low toxicity, and short duration of treatment, and standard palliative care schemas: 8 gray in 1 fraction, 20 gray in 5 fractions, and 30 gray in 10 fractions meet these principles. But nowadays, the palliative care opportunities have increased due to progress in systemic therapy, due to new high-precision radiotherapy technologies, and due to oligometastatic disease theory. The superiority of stereotactic ablative radiotherapy over standard of care palliative treatment in patients with oligometastases was demonstrated in SABR-COMET, the well-known randomized trial. Stereotactic ablative radiotherapy was associated with an improvement in overall survival in comparison with palliative standard of care treatment, but 3 of 66 patients in the SABR group had treatment-related death. So the careful patients selection for more or less aggressive treatment is essential. International consensus on radiotherapy in metastatic non-small lung cancer was published in 2022, and the first consensus states that palliative radiotherapy is a safe and effective approach for patients who present with cancer-related severe symptoms. And besides, the special attention is paid to patients with oligometastatic disease. Oligofocal disease states must be confirmed by PET, and appropriate incorporation of radiotherapy as a concurrent consolidation or salvage therapy makes it possible to overcome the resistance to the systemic therapy and even achieve long-term survival. And today we would like to introduce the results of palliative treatment of 2 patients with a single and with a multiply lung metastasis. And my colleagues, Ani, will introduce the first patient.
Hello, dear colleagues. First of all, we want to present you first clinical case. It's about a woman. She has adenoid cystic carcinoma. So first of all, I want to say that is so rare and some aggressive type of tumor. And first of all, start of disease was in the first step was resection of the upper lobe of the right lungs. On those time, we thought that it's a primary tumor, but after that, we found it the first tumor, primary tumor, on submandibular salivary gland. And second step was a surgical step, left cervical lymphadenectomy, and reconstruct surgery. But after that, this patient had a progressive disease, and first of all, we gave to her radiotherapy. After that, was progressive disease again. It was lungs metastasis. And this time we started systemic therapy. It was target therapy, lenvatinib, but without good response. After that, next progressive disease in lungs again. And second line of therapy was paclitaxel, carboplatin, plus target therapy, bevacizumab. But it's not a good response again, and she had a progressive disease and was started third line of target therapy it was a surfing. After that, no objective response for these lines of therapy, because this type of tumor is not unsensitive for systemic treatment, chemo or target therapy, and this is why was started palliative radiotherapy.
Dear colleagues, I would like to continue our case. Because of continuous progression, we choose palliative care for this patient. And the first step was radiation therapy for tumor mass in the right lung. You can see on the slides, it's a great volume of tumor mass, and we choose classic palliative regime in IMRT technique, 30 grays in 10 fraction. It was at October-November 2022. You can see in these slides initial CT scans with this mass, and after our radiation therapy, palliative radiation therapy, we have partial response, and tumor mass volume was decreased. But after 1 month, we have next follow-up, and on these CT scans, we see increased number and size of other lung metastases outside of our radiated volume, and respiratory failure. And in this case, we choose all lungs irradiation. We should choose the best technique of radiation therapy. Because of this, you can see 2 plans of radiation therapy in VMAT and in IMRT technique. And in the left side of the slides, you can see our clinical goals summary for these 2 plans. And as you can see, VMAT plans is in some points better. For example, in these plans, we don't have a great maximum point in the volume of lungs. After this treatment of all volume of lungs, the patient had a progression in all metastases in lungs, but our first site, great mass tumor on the left, on the right lung, that we irradiate in the first step, it's continual response, and you can see it's partial response in this site continues. After our treatment, we have pulmonitis, the third state. Patient have problems with breath at minimum load. We treat this patient with corticosteroids in standard regimens and oxygen. And you can see after to the next follow-up, she had a regression of the pulmonitis and dyspnea. But it's continuous progression in metastasis in lungs, bones, and new metastasis in spleen. Next patient, it's female too, 77 years old. She was diagnosed rectal cancer at 2006. It was complex treatment with surgery and chemotherapy. After many years, she had progressive disease at left lung, and doctors choose pneumonectomy for this metastasis. but after 3 years, it was progression in right lungs too. And for this mass was choose radiosurgery and chemotherapy. Next progression was after 4 years, and it was in right lung too. It was local recidive. And this patient visited our center at 2021, and we choose for her stereotactic radiotherapy. It was with deep inspiration breath hold, and we choose regimen with total dose 40.5 grays. It's bed more than 170 grays. After our treatment, patient had pulmonitis, and she received treatment, corticosteroids and oxygen too. And after 1 month of treatment, all symptoms are regressed. But the next local recurrence in this site was diagnosed, and patient choose treatment in Germany and received ablative radiotherapy in CyberKnife. It was 42 grays. Next follow-up, she continues in our center and at September 23, it's a stable disease for this patient.
So we have seen that the timely and available radiotherapy could offer rapid symptom alleviation in patients with metastatic cancer resistant to systemic therapy. And for the first patient, radiotherapy was used for symptom palliation. Local ablative therapy makes it possible to delay the use, the application of more toxic systemic therapy. And in the other way, it in patients, in some suitable patients, with appropriate systemic therapy, it can prolong survival. I think that these clinical cases are not usual, and I know that you want to discuss some problems of stereotactic radiotherapy of lung metastasis, and I suggest to do it after your presentation. Thank you for your attention. Thank you.
Thank you very much about the presentation from Samita's team. It's a very nice case with two cases. One is the adenocytic carcinoma of the salivary gland, and the other is the rectal cancers. And I think that it is the same situation in Vietnam, in which we see there sometimes we have so many cases like this. But actually, my first comment is nowadays, beside the this stage, that you have to define where the tumor metastasize to, or how big the tumor lot is, to choose for between the local ablation, local radiation, or systemic therapy to shrink down the tumor, and after that we have the ablation of the tumor. By the way, you have to be mentioned to the biology of the tumor, because the two cases, the first case is I think that it is a chemo insensitive one. So you can see that several targeted therapy and also chemo couldn't work on the patient itself. And also for the second case, I can see that you have given the patient radio therapy, but I could like to hear about your comments about the biology of the tumor on the second case and how to add the systemic therapy on this patient because they're 77 years old with rectal cancer. I think that yes, sometimes it's the oligometastasis, but in Vietnam, in Ho Chi Minh City Oncology Hospital, we have to give the chemo first in combination with the targeted therapy like bevacizumab or cetuximab. Beside the biology RAS and RAF situation, also the MMR status, micro stability status, or the mismatch repair gene status, in order to choose the right biology treatment for the patients. So I think that there's the two factor that we should concentrate on. The first is staging, and also the second is the biology of the disease itself. So, what do you think about this? About the first case is the biology of the adenocytic carcinoma, and the second case, how about the systemic therapy and also the bio